Welcome, everyone. Thank you so much for joining us this evening. I just want to begin with acknowledging that Lifemark Health Group team acknowledges that our work spans many territories and treaty areas, and we are grateful for the traditional knowledge keepers and elders who are with us today, those who have gone before us, and the youth that inspire us. We recognize the land and the benefits it provides all of us, and we invite everyone to reflect on the past and present history in their particular geographic area, and for us each to think about what we can do to work towards reconciliation. So thank you again, everyone, for joining us this evening. We are very excited to have all of you with us. We are even more excited to be sharing this opportunity with our partnership with PC Health. So some of you may be coming to the webinar through finding out about us and the session through PC Health app, and others through Lifemark. And we'll take a couple of minutes at the beginning here to let everyone know who the two organizations are. My name is Krista. I will be your moderator for this evening. I work with Lifemark, and all of these lovely ladies who will be speaking to you are some of our great team members. I'm going to first just tell you a little bit about Lifemark. So Lifemark is one of Canada's largest physiotherapy company. We have national coverage with over 300 clinics across the country and over 2,500 clinicians across the country as well. Really focused on providing quality care to Canadians and trying to help them enrich their lives and their health through movement. And we operate under a number of different brands across the country in our clinics, as well as other service delivery items. We also want to invite Gloria from PC Health to just briefly introduce all of you to what PC Health is. Gloria?
Thanks so much for the introduction. I'm really excited to be here today to talk about PC Health. PC Health is a digital tool that's available both as an app and on the website pchealth.ca. Our goal is really to support Canadians by enabling you to conveniently access healthcare and achieve your goals. So the first thing I want to highlight is that you can access healthcare anywhere. On the app, you can book and manage appointments for pharmacy services like vaccines and minor ailments like pink eye. You can also easily book with Lifemark clinicians and other healthcare professionals such as physiotherapists, massage therapists, and mental health counselors. Another awesome feature is that you can chat live with a healthcare professional for free, depending on your province availability. We have registered nurses, pharmacists, and dietitians available. The chats are absolutely free, confidential, and privacy protected. Prescription management is another incredibly convenient feature that we have. With a touch of a button, you can refill your prescriptions, receive prescription pickup notifications, and access your medication history super easily. And last but not least, you can educate yourself and achieve your health and wellness goals while earning PC Optimum points, which is super exciting. We have a catalog of over 150 different programs where you can earn up to 1,000 PC Optimum points just for completing a program. We have programs in many categories, including diet and nutrition, skincare, diabetes management, women's health, and much, much more. Which leads me into our next slide. An amazing offer that we have live right now that supports the Shoppers Foundation for Women's Health and International Women's Day, which if people don't know is tomorrow. So happy International Women's Day. You can scan the QR code to download the PC Health app right now. So the QR code that you see on the screen. And once you've downloaded the app, you can enroll in our featured women's health programs. You can earn up to 8,000 points by completing the programs that are available that we're promoting, such as heart health for women and functional fitness for longevity. There's something for everyone. There's tons of really awesome educational information on there. And the best part is that for every point that you're earning, PC Health will match and donate points to the Shoppers Foundation up to 25 million points. So we really want to donate all 25 million of those points to the foundation. So please scan the QR code and get started today. We would love your participation and also would love to reward you for supporting women's health. So thank you so much for your attention.
Thank you, Gloria, and thank you for partnering with us and bringing this great session to all of our attendees. All right, so a few housekeeping items here before we get going. Sorry, wrong way. Just wanted to let everyone know that we are using what's called Zoom webinar. So it may look a little bit different than what you're used to if you are used to using Zoom for meetings. You will notice that as a participant, you are not able to turn your camera on or unmute. It's because we have a lot of people on the line with us this evening, and so we didn't want to disturb the recording. And so we are recording tonight. We will be sharing the link to the recording to all of you directly into your inbox within about 48 hours after the session. And then we'll also be asking for your feedback in that message. So please watch out for that email so you can tell us what you thought about tonight's webinar and also rewatch or watch any part that you may have missed this evening. We also encourage you to use the Q&A feature in Zoom. This allows our team of pelvic floor physiotherapists who are in the background of tonight's session to answer as many of your questions as they possibly can. I will say that we are not able to provide individualized advice in this environment, so please try to keep your questions to a more general nature, not necessarily about your specific condition or scenario. You're definitely best served if you're able to kind of speak directly to a healthcare provider about your scenario and have an assessment of your particular condition. But we're really excited to be here to share with you some of the great knowledge that our pelvic floor physiotherapists have and are willing to to teach us all a little bit more about our pelvic health as we go through this evening and into International Women's Day. So thanks for that, Gloria. All right, before we get started, I do want to introduce our two amazing panelists. First, we have Ghosh. Graduated from the University of Toronto with a Bachelor's of Science in Physical Therapy in 2003 and completed a Doctor of Physical Therapy at Boston University in 2010. She began treating clients with pelvic floor dysfunction secondary to oncological intervention while working in New York at Memorial Sloan Kettering Cancer Center. Since coming back to Toronto, Uma has dedicated her efforts to treating women and men with pelvic floor dysfunction, and she currently practices at Lifemark, Leslie and Shepherd in North York, and coordinates the pelvic health curriculum as an adjunct lecturer at the University of Toronto in the physical therapy department. Uma, will you just say hello to everyone, please? You have to say something so that your video will come on.
Hi, everybody. I can see myself. I just assumed everyone could see me too.
No. Excellent. Very good. And our second panelist for this evening is Lazareck-Devlin. And Alana obtained her Bachelor of Medical Rehabilitation and Physical Therapy from the University of Manitoba in 1996. She became a certified manipulative therapist in 2002 and began to pursue further advanced education in her passion for women's health. She is engaged in advanced training throughout Canada and the US, and in 2018 and 2019, she successfully obtained her Certificate of Achievement in Pregnancy and Postpartum Physical Therapy and the Certificate of Achievement in Pelvic Physical Therapy through the American Physiotherapy Association. She also completed her doctoral degree in physical therapy in the summer of 2021, and she's proud to be an instructor and teaching assistant and work alongside a number of different gynecological and urogynecological health professionals. So Alana, will you also say hello to our attendees?
Hello, excited to be here. Thank you everybody for coming to learn about your bodies.
Awesome, great, thank you very much. All right, so without further ado, we want to dive into some of the key questions that I'm sure many of you may be having out there. So I'm going to kick us off and go to Uma. Uma, I'm going to ask you to just start us off with some basic information, start us all off on the same page. What is the pelvic floor?
Thanks, Krista, and welcome everybody who has joined us today. Yes, anatomy is always a great place for us to start, and I can attest to myself that the pelvic floor really wasn't even a part of our curriculum when I was in school. So this is a great place to kind of start our topic of conversation. Before we actually start talking about the anatomy, though, I want to make sure that we say that for the scope of our talk today, for the purposes of our talk, we're really going to be talking about the anatomical features of the pelvic floor musculature. Alana and I are well aware of gender fluidity, but just for the purposes of this next part of our talk, we're really just going to focus in on the specific anatomy. So I guess this is a good time for our slide. Okay. So in the slide here, as you can see, we have a male pelvis and a female pelvis. So if you have a pelvis, you've got a pelvic floor. And so we can kind of see here in this slide that we are sort of looking at a bird's eye view down into the actual pelvis. And so and I'm going to pull up my model here so we can kind of see a 3D view as well. But the first feature of the pelvis that we should also look at before we talk about muscles is the actual bones itself. This is a very strong and stable place because we do not house the human race in this house or build people in a house. That's easy to break. So the pelvis structure itself is extremely, extremely structurally strong. And when we're building babies is not a time that they decide that they're going to give up. So it's very, very strong. Now, the actual muscles itself, if we look on the slide, we're looking at a bird's eye view, but if we kind of look at the features of these muscles, they're kind of attached from front to back and from side to side. So they kind of look like a bowl, or we're going to actually use the analogy of a trampoline to tell us how these muscles actually work. So I'm going to use my model again so we can kind of see. So the front is the pubic bone here. And if we turn this pelvis around, the back, we have the sacral bone. And we also have the tailbone, which is also called the coccyx. So the muscles, if we look from the inside, attach from the back of the pubic bone, they wrap all the way around and attach back here to the tailbone. So they are kind of front to back and side to side like a bowl. Now, the actual muscles between the male pelvis and the female pelvis, if we look at our slide, there's really very little difference between these two groups of musculature. So aside from the middle, if we look at the female pelvis, there is a muscle that sort of encircles where the vagina is. On the male side, this muscle encircles the prostate. So that layer of musculature, the deeper layer of musculature, is very, very similar, whether it's male or female. One difference that if we look at the superficial muscles that are sitting outside, and of course, this is a female model, but the only really one difference between the superficial muscles for females and males is that this muscle that is underneath the labia for women is actually midline for men. And that's quite literally the only differences between the muscles of the pelvic floor. Of course, there are other featural differences between the actual pelvis and other features inside the pelvis, but as far as the muscles go, it's actually pretty similar. So in terms of the roles of the muscles, they actually play a lot of really important roles. So we're going to package them up with a nice little bow that we're going to call the 5 S's. So the first role that they play is a sphincteric role, which means it's just a fancy word for the control of our bowels and our bladder and flatulence. So the first role that they play is to make sure that things that we don't want to come outside are kept inside. And when we want them to be evacuated out of our bodies, they let go and they allow this to happen. So that's our sphincteric role. The second role that they play is a role in support. So they play this sort of suspensory role, or almost like a shelf that the pelvic organs are contained within. So that supportive role is obviously very important. The next role that they play is in sexual appreciation. So all these pleasant sensations that we have with intimacy and orgasm, this is a big role that these muscles play as well. And a really good reason why we want to keep these muscles very, very happy, of course. The other role that they play is this role in circulation. So they kind of have this sump pump sort of feature that they can pump out lymphatics and circulation within the pelvic girdle. And then the last role that they play is a role in stabilization. So they help to reinforce the joints of the pelvis. And that's also partly what keeps this structure nice and stable and strong. The other role that these muscles play is also a role in core stabilization. So if we go to the next slide now. Okay, so the pelvic floor is part of the core, and we need to really make sure that we talk about the core because there's a lot of misinformation out there. So the core that we are talking about is not the same core that they talk about at the gym. So when someone says brace your abs or turn on your core, these are not actually muscles that we're using that actually has any influence over the actual core itself. What we're talking about are those beautiful six-pack muscles that are very nice to look at, but they're not actually part of the inner core unit. What actually is part of the inner core unit is our diaphragm, as we can see in this diagram here. The diaphragm is our main muscle for breathing. And fun fact, in a singular day, we breathe 24,000 times minimally. So that is a lot. And there is nothing more basic that we have to do as humans than to deliver oxygen. And so our brains are really interested to make sure that this diaphragm is working as optimally as possible. So diaphragm is the top of the core. Underneath the core is not an empty canister. We actually have a lot of stuff packed into that tight little space. Liver, stomach, spleen, pancreas, all kinds of organs that are packed in nice and tight, not just floating around everywhere. So that area is almost like a balloon that's fully inflated and already under a lot of pressure. So if we have this dome at the top, balloon filled up in the middle, the other end of that balloon is our pelvic floor, or as I mentioned before, a trampoline. So the breathing mechanism involves the diaphragm. As we breathe in, of course, we are breathing down, not breathing up. This is confusing for people, but the air is moving into our nose and moving down into the lungs. So the diaphragm contracts and also descends to allow that air to come in. As it's descending, it's going to pressurize that balloon through the top. And of course, if you press a balloon that's already full from the top, that pressure will go down through it and come right out the bottom and land on our trampolines. And this is totally normal. This is exactly what's supposed to happen. As you jump on a trampoline, trampolines stretch and accommodate. And that is exactly how the pelvic floor responds to this pressure. All of that is happening on an inhale. On the exhale, it all reverses. We jump off that trampoline, we pressurize the bottom of the balloon, air goes back to the top, diaphragm back to the resting position, we exhale. So what actually stabilizes the core, this whole scenario of the core, is not tightness of muscles. When we're taking a dynamic system and we're making it rigid, it actually doesn't help it to work very well. It actually makes it impedes the way that it works, right? So when we tighten, we actually increase the pressure into that system, and naturally that pressure also goes down. So it's actually the pressure in the system that stabilizes the spine, not tightness of muscles. That's really important to understand. It's not the rigidity of the muscles, it's actually the pressure that we generate in the system that creates that stability. Now, there's a lot of ways to disrupt that system, and Alana is going to go through all of these things in a minute. But when we disrupt that system, we're going to increase the pressure into that system. That pressure is going to head down, and our muscles basically have two ways that they can respond. They can barricade and try to hold it up, right? And that's going to make our trampoline nice and short and tight. Or they can just get overwhelmed and not be able to fight back, right? So if you have a trampoline that's really short and tight and you jump on it, you're either going to rip it right through, or you're going to break your legs. Those are the two options. Or if you have a trampoline that can't fight back, it's going to collapse, or you're going to rip a hole through it. So these are kind of the ways that we develop pelvic floor dysfunction. And what the take-home message is from that whole section is that the core is a pressure system. And when we disrupt pressure, that's when our pelvic floor muscles are going to start talking to us.
Amazing. Thank you, Uma. And thanks for kind of giving some great analogies and kind of helping all of us understand this a little bit more, because it is really quite complex. All right. So Alana, we're going to go to you now. Uma's done a great job of telling us where all these things are and how the basics of it work. Can you tell us how we might know if there's an issue with our pelvic floors? What might be kind of some of the common signs and symptoms?
This is kind of where it gets very interesting. Uma did a great job of kind of explaining the anatomy of that whole core pressure system. So we're looking for, exactly as she said, reasons why this pressure system isn't doing a good job containing pressure. So if your core isn't containing pressure well, if that core canister, I like to call it a Coke can. I don't know why I've chosen Coke, but it'd be Diet Coke if I had a choice. But it's like, if it's not containing things are going to leak out. That's where people will pass gas when they don't want to, or, leak urine or fecal material, hernias, a whole bunch of stuff, which we'll kind of go through. But the other P, I just thought about this while you were talking, Uma, which we have talked a million times about this, is I almost feel like we should add another P, and that's protection. So the other thing that your pelvic floor is really involved in is protection. So when we think there's an impending threat, or if you think that something is going to be dangerous, or if you've had a history of having any kind of pain, especially pelvic pain, low back pain, persistent hip pain, a lot of people will clench their pelvic floor as a way of protecting. It's basically your body's way of closing off the orifices that lead to your organs that make you more vulnerable. This is a really old reflex we have. It's kind of part of that flinch reflex. So, and sometimes if you're in that protective, we're stuck in that protection mode, then we don't have that trampoline that Uma was talking about. That's so important. We don't have a give in the system. And again, this is why we are going to repeat this a million times. Kegels are not the answer for everybody for that reason, because we need to restore the movement and the robustness to that system. So the way we usually tell if somebody's having a problem with their pelvic floor, whenever people are asking me, do I need to go see somebody? Not everyone needs to go see someone, but there are clues you have. And I like to call, because we like to simplify things around here. So we like to call it the 4 Ps. So if you think of what is in that pressure canister sitting at the very, very bottom with all the openings that are running through your pelvic floor, there are basically several organs. So one of the organs, the very first organ we see on the left in these slides, is our bladder. So your bladder is where urine collects. Your urethra runs through your pelvic floor. So you could have problems with your urine, or because we like to be simple, we call it pee. Same thing, poop. So same thing, the very back passage in all of us, that is where your rectum stores stool, and then it comes in. Your anus is where the stool exits, also has to run through your pelvic floor. So that has to function well. So in terms of bowels and urine, you want to make sure that you have control. You should be able to hold your urine and not leak when you don't want to. And by the same token, when it's time for your body to go to the bathroom, you should be able to go and you not have a hesitation. You shouldn't have to sit on the toilet for a while and just kind of wait until your body kicks in. When it comes to stool, it really is a big deal, because I can't tell people how much constipation and chronic constipation cause so many problems for pelvic health in general. So you should have the feeling and the urge to go to the bathroom. Generally, it's 15 to 20 minutes after you eat in the morning. And you should be able to sit down. You should control when you go to the bathroom and not have to lose it when you are not planning on it. And at the same time, it shouldn't be hard to have a bowel movement. You shouldn't be pushing and pushing. And it's that repetitive pushing on that trampoline that really, really does a number on it often. So you should be able to have bowel movements when you want to and hold them back when you want to as well. When it comes to pain, pain is really our body's way of telling us that it's worried that there's going to be tissue damage, or we've gotten used to the fact that we've had some type of tissue damage in terms of chronic pain. So in pain, you should not, pain with intercourse is not normal. I know a lot of us are told that sometimes, your first attempts at having intercourse may be painful, but this should not be a persisting thing, over years or months or weeks, even for that matter. So any kind, and this goes for males and females, any pain with any type of sexual activity, really go seek treatment, because sometimes there's very easy answers and we just don't talk about this stuff. So persistent low back pain, you've been to physio, you've been to chiro, you've been getting massages for years and just nothing is going away, and they just can't get to the problem. Often it's your pelvic floor musculature that's overlooked, because your pelvic floor muscles really they extend into your hips, and all of your hip and low back muscles really are fascially, like the connective tissue is really, really connected with your pelvic floor. So often we'll see a lot of pelvic floor tension or pelvic floor dysfunction when people have persisting low back pain. So any type of pain with menstrual cycles, not normal. Your menstrual cycle, your period should never stop you from doing something you've been looking forward to doing. You may have some cramping that's mild, but really nothing that any type of Advil or Aleve or something shouldn't help you with for a day or two. Otherwise, we really should look into why you're having problems. So pain generally in your pelvic area, let's look into it, because there's easy answers sometimes. And then pressure. So often people will have a sensation of pressure. I've just seen 2 people this week that are like, I feel like there's a mandarin orange stuck in my pelvis. So as soon as we hear the word pressure, we worry about prolapse. So I think that's on the next slide. Prolapse, a lot of women have it. There's upwards of 50% of women probably have some degree of pelvic organ prolapse. And prolapse is not life-threatening. I have people running into my office so concerned that somebody has told them that they have prolapse. And it's simply a descent of one of your pelvic organs kind of through pressure to somewhere we don't want it to be. So it's kind of descending into especially this vaginal space. Men do not tend to have so much prolapse. So in this in this picture in particular, this woman's bladder prolapsing. So it's just things follow the path of least resistance. And so she had either a deficit or connective tissue that was deficient in the front of her vaginal wall. So her bladder is sitting against it, and it's just going to kind of like pocket or move down through that vaginal space. You can also have prolapse of your uterus. You can have prolapse after you've had a hysterectomy. You can have, it's called a vaginal vault prolapse. You can have prolapse of your rectum, which is called a rectocele. And you can have prolapse of some of your little loops of your small bowel. It's called an enterocele. So lots of things go wrong that I think our parents never told us about as we were growing up. The other thing is, as soon as somebody feels pressure, it's not always prolapse. It also can be muscular dysfunction. A lot of people, if they have a really chronically tight muscle, they may feel that as pressure. It's almost like when you have this kind of like knot in your shoulder and you kind of feel that lump, like it kind of is a sensation of pressure. So often we'll check people to see if they have any prolapse, but also to see if they have any kind of muscular dysfunction. So those are the 4 P's really. It's kind of looking at issues with pain, pee, poop, and pressure. And that's kind of how I tell people if they need to come see me for sure. Oh, you're muted.
So I clicked the button, but it didn't do it. I always like the little kind of acronyms that you guys share, because it does help to kind of stick that information into my brain so that I can recall it later. All right, Alana, I'm going to stay with you because I think probably many people are wondering, kind of, what are some of the risk factors that might lead to pelvic floor dysfunction? I know I've even seen some of the Q&A, kind of some of the questions around, like, could it be related to this? Could it be related to this? So tell us, what are some of those risk factors? Or are there risk factors? I guess I should have said.
Yeah, there are definitely risk factors. I think a huge risk factor for most of us, to be honest, is we have no information or knowledge. We're not taught anything about our anatomy or prevention strategies at all. We're kind of taught whatever we're taught in high school, and then we're kind of left to be like, well, that should serve you for the rest of your life, no matter how many stages and ages you're going through. So part of it is also, if I go back to just talking about like different types of leakage, even with urine, not everybody leaks for the same reason. So a lot of people will have, it's called stress incontinence, which I don't really like the word stress, because it almost could be like, it should be called pressure incontinence, almost like something is failing in that whole pressure system Uma was talking about. So that would be coughing, laughing, sneezing, jumping, running, you're leaking with that. So that's stress incontinence. It's not always because of a weak pelvic floor. It's because of a dysfunctional pelvic floor or a dysfunctional core. And the other reason people leak is when they have that, oh my goodness, I have to go now and I'm not going to make it to the bathroom. That's more urgency, or they're going to the bathroom too often. That's actually a dysfunction more of your bladder. So that's where we have to kind of improve your bladder function, or improve the communication between your bladder and your pelvic floor. So just kind of knowing what's normal. You should be peeing every 2 to 4 hours. You shouldn't have to pee more frequently than every 2 to 4 hours. We also shouldn't be holding our bladder for longer than about 4 hours. You should, if you're under the age of 65, 0 to 1 time to wake up at night is normal. Over the age of 65, we actually do create more urine at night. So waking up 1 time is totally fine. Having bowel movements is normal, anywhere between 3 times a day for some people, or 3 times a week for some people, but it shouldn't be hard to get out. So it should be kind of easy to have a bowel movement. So many times we see people and they're dealing with more than one factor. And in terms of risk factors we look for with people, if you see something you have on this list, that does not mean you are predetermined to have pelvic floor dysfunction. It's just, risk factors do not mean it's not causation. It's just like, we want to kind of pay attention to if you have a whole bunch of these and if you're having problems. So this is a very, very cursory list. We could go probably on about this forever, but obviously we know that having a history of being pregnant as well as delivery is definitely a risk factor for having pelvic floor dysfunction. We know that there is more pelvic floor dysfunction with vaginal deliveries, especially with what we call operative vaginal deliveries, where you've used forceps or vacuum, or where you've had a significant tear. So we call it grade 3 or 4 tears. So that predisposes you to some pelvic floor injury. But also, I think that pelvic floors and vaginas heal really well, and we just have to know what to do for them. So we don't give ourselves enough credit. In terms of medical history, there are age-related changes. I think somebody asked about that. Definitely, as we see our estrogen levels go down, you have the robustness of the tissue in our vaginal canals. Our vaginal canals often will become drier and thinner, and you lose that muscular robustness. So your trampoline really becomes stiffer, so it's harder to control. You have changes to the nerves at the bottom of your bladder with lower estrogen. So people will have increased, sometimes urinary urgency. So there definitely are age-related changes. We see a lot of people will develop more problems as they go through menopause, or as like they're a few years into menopause and they don't have as much estrogen. Genetics can play a role. You want to find out if maybe your mom or your aunts had any kind of pelvic organ prolapse. Maybe some of that is the connective tissue genetics you're born with. So some of the collagen and elastin that you're born with. Again, like one further down is connective tissue disorders. We know there's a huge spectrum of, it's called hypermobility disorders, that may predispose a lot of women. They've never been pregnant, and I'm seeing them with pelvic organ prolapse or kind of some connective tissue loss of support. So there's many other things there's MS we talked about, anything that's going to affect your nerves, a previous history of stroke, a previous history of spinal cord injuries. Obviously, you know, if you have any kind of nerve impingements, disc herniations, that can predispose people to having pelvic floor problems. Any kind of gastrointestinal disorders. So we know that a lot of people with inflammatory bowel disease, so that those people will tend to have a bit of pelvic floor disorders. Any type of history of radiation or cancer treatment may have problems. And again, it's anything that's really causing pain or discomfort in that lumbopelvic, in your abdominal pelvic area, you are going to try and compensate to alleviate that discomfort. And then there's lifestyle. So a lot of it is we don't know how often we're supposed to pee. We're sometimes told from the time we're little children, oh, pee just in case, pee just in case. So a lot of people pee too frequently, and your bladder is actually a muscle. It's not just this balloon that fills and empties. And because it's a muscle, you can train it in really bad patterns where you're just peeing too frequently and it doesn't know that it has to hold on. So you should be able to hold again for about 2 to 4 hours, but there's many more factors in that. Do you have an occupation where you're doing a lot of heavy lifting and grunting, or like really holding your breath when you're working out in the gym? Because as Uma showed, your diaphragm and your pelvic floor really work together. So if you're holding your breath and you're going, huh, your diaphragm is not moving. All that pressure is trying to seek its path of least resistance south somewhere. So we know where a lot of times that is. Are you a smoker? Do you have a chronic cough? Any type of asthma, breathing problems? There's some medications that may predispose people to having more bladder urgency or pain and constipation. And again, I think I spoke about the learned behaviors, which is really not to go too often. Every time you wake up at night, don't run to the bathroom. Try and see if you can hold on for a bit. So I think that's it.
Great. Thanks, Alana. So yeah, I covered off a lot of great examples there. And I, like you said at the beginning, just because you see maybe some of these things on the list as being things that you identify with doesn't mean that it is a pelvic floor problem or you're going to have one. But if you are hearing these things, quote unquote, from your pelvic floor, it's a great sign to talk to someone who's an expert in this area. Pelvic floor physiotherapists are definitely kind of well versed in that area. So thanks for that. So Uma, I'd imagine that a lot of folks out there that are listening to us are saying, okay, like that's a lot of risk factors. How prevalent are pelvic floor conditions? Like, is this something that everybody has, or what's going on?
All right, well, I think that in terms of prevalence, we probably have some idea of the fact that it actually is a prevalent issue because of all the commercials that we get to see on television nowadays, right? All sorts of undergarments and devices and, like for small bladder leaks or whatnot. So yes, this is a pretty prevalent problem, and I'm about to throw out a whole bunch of statistics at you, so everyone get ready. So the first stat is that 3.3 million Canadians, that means 10% of the people living in this country, are experiencing some sort of urinary incontinence issue. This is not unique to women. It's not unique to older people. It's not unique to any one specific group. it's across the board. There are equal amounts of incontinence issues that affect everyone pretty much. And there are some statistics actually even surrounding that that's actually even more concerning. So 15% of female athletes between the age of 12 and 19, these are young women who are nulliparous, which means that they've never been pregnant and never had babies, are also experiencing urinary incontinence. There is the number one reason why family members have to institutionalize their family members is because of incontinence. The burden of having to care for someone who is incontinent is exceptionally high. So this is the number one reason why family members have to institutionalize people that they are caring for. And probably the most horrifying statistic of all is that half of us are going to end our lives in diapers. And that's terrifying to think about it. So hugely prevalent when it comes to incontinence. Now that's just incontinence. Now, if we kind of move on and start talking about pelvic support, Alana has already alluded to this. 50% of women are going to have or experience some sort of pelvic support issue in their lifetime. That's 1 in 2 women. That's, again, huge. May not necessarily be symptomatic or something that necessarily has to be intervened for any reason at all. But again, it is prevalent. It does happen. As far as pelvic pain issues go, 1 in 4 females and 1 in 3 males will experience pelvic pain issues. And I know that's a really interesting statistic because it's 1 in 3 males, which it seems like it's more men than it is women. But I'm going to say clinically, there are many, many, many people that come in to see me for something that has nothing to do with pain. And when we go through our assessment, we actually uncover pain issues that they didn't realize that they had, or they had thought it was a completely normal situation. So as far as I'm concerned, I think that 1 in 4 number is hugely an underreported number. That number definitely has to be way higher than that. And then the final stat that I want to talk about is to kind of pull in our pregnancy population. In pregnancy, up to 70% of pregnant women will experience some sort of pelvic girdle pain. And we kind of call this pelvic girdle dysfunction. So usually these symptoms kind of start in this week 26, 27 week mark, because that's when we really pop and, the shift in gravity and all of that stuff really takes place at that point. And symptoms can include back pain, hip pain, groin pain, sciatica, pubic pain. It can have some weird patterns where we can sit for some time and we're good. And then 20 minutes in, our pelvises start to hurt. And then we try to stand up from a chair, excruciating. First couple of steps, terrible. Then we walk a little bit further and it eases off. And then 20 minutes into the walk, it's right back again. Turning in bed, terrible, excruciating pain. So it may seem like it's no rhyme or reason, but there's actually a very specific pattern to this particular pain. And if you are experiencing this, I'm sorry to tell you, it's not going to get better the more pregnant you get. And also it's a small percentage of people actually continue to have this discomfort even after the birth of the baby. So if this is something that anyone out there is actually listening to, please, please, please get help, because it's a quick fix. We're talking 1 to 2 sessions and you are good. There are so many pregnant women that come to see me and they are in terrible pain. And then by the time we're done, after even that first session, they're in tears because they are relieved of this pain that they've been experiencing for so long that has been so impactful. So yes, hugely prevalent in all walks of life. Our take-home message in terms of what we want messaging to be today is that these issues are common. They are not normal. And more importantly, they are absolutely treatable. So if you do think that you're dealing with something, there is help out there. Talk to your healthcare practitioner, because there's something that can be done about it.
Thank you. And I always remember, Uma, the first time that you said that to me, that it's common but not normal. And I was like, oh my gosh, that just says it all. So it's common, not normal. It doesn't mean you have to live with it. Do kind of go and get some help if you have any of these sorts of symptoms. So let's transition. So I'm going to stay with you, Uma, for a second. Can you tell everyone what exactly is pelvic floor physiotherapy?
Yes. Okay. Well, that's the topic of discussion today. So pelvic floor physiotherapists are really orthopedic therapists, because the pelvis is an orthopedic place in our bodies. And so we are really under that umbrella of orthopedics. What actually sets us apart from orthopedic therapists, though, is that we perform internal pelvic examinations and treatments. And so this particular skill set is what we call a controlled act. There are very specific healthcare practitioners that are mandated to be able to perform this specific skill set. And in order to perform this particular skill set, we have to perform adequate training, and we have to show competence in being able to perform this skill set well. And in doing so, different provinces have different mandates. Here in Ontario, which is where I am, we have to roster with our college to show that we are performing this controlled act, and we have done our due diligence in terms of the training that we need to perform and show competence in actually performing this particular act. So that's kind of the difference between pelvic health physiotherapists and orthopedic therapists, that we actually have a specific skill set that we have done specific training in.
Great, thank you. And Alana, will you talk a little bit about what an assessment with a pelvic floor physiotherapist might entail? Like what should someone expect when they come to see a pelvic floor physio?
Well, first of all, most people are extremely nervous, which I think after about 10 minutes, they feel at ease, and they actually end up leaving really feeling like they learned a lot about their bodies, and they've learned things they've never heard of before. So I think it's a great experience. I like to think, most people tell me. But generally what you can expect is we'll usually get you to fill out some paperwork before, just so we can kind of abbreviate the session, because sometimes when you live in the world of a pelvis, you have to deal with many of the systems that run through it. So we're going to be asking you questions about your urinary function, sometimes sexual function, bowel function, low back pain. Do you have a history of falls? Do you have a history of neurological dysfunction? Have you injured your tailbone? So a lot of people don't think, like they're like, oh, well, I'm not here for my bowel dysfunction. But then when you talk to them again, exactly like what Uma is saying, you realize, oh, like they actually are constipated, or they do have pain with sexual function or intercourse, and many times it's really related. So there's a lot of talking at the beginning. We really do a long history, a thorough kind of explanation and description of how this all fits together and why it fits together, because I think that's really important. And then we'll move on to a physical examination, whereas we will start from the outside. The first thing I look at is somebody's pelvis, and to see, what's going on with their pelvic musculature. So in terms of a musculoskeletal exam, are any of their nerves involved? Do they have any nerve deficiencies? What's happening in their abdomen? Again, like we talked about that canister, is their diaphragm mobile? Do they have anything else happening in their abdominal wall with any type of restriction, which would again make that canister not be so mobile and kind of resilient? And then if the person feels comfortable, there's many people we see that they have had potentially a history of trauma. They've had some bad experiences. You do not have to do an internal examination for pelvic floor. It's definitely the best way really to see what's going on as the muscles live internally. But at the same time, don't let that stop somebody from going to see a pelvic floor physio, because we can do a lot of things externally. So if you've had a discussion, if the therapist has then described to you what they are doing and why they think that it's necessary to move on to an internal examination, only with the consent and your consent and ongoing consent, because at any time, I always tell people, this is your body, not mine, and you're the boss of your body. So you just tell me what you want, and we can stop at any time. So consent is a huge thing in what we do, and we really drum it into people when we're teaching people to become pelvic floor physios. So only with that consent would we move on to do an internal exam. We really don't use any fancy equipment. We generally don't use any speculums or any kind of other devices. It's really just kind of, a gloved hand and just making sure that things are comfortable, because no matter what, this should never be painful. Because so that's the other thing people are really worried about when they've had pain with intercourse or pain with speculum examinations in the past. It should be nothing like that. So generally, you're also in a private room So you're not in, like, if you've been to physio before, you're not in this curtained off room so everyone can hear, all of your most private things that you're talking about. So you're in a private room, one-on-one. There's usually one therapist, unless we happen to have a student. If there is a student, you do not need to have the student there. That's, again, only with somebody's consent. And most of the, I'd say, pelvic floor physios are female. So if you'd prefer a female, they're generally female. We do have within the company a few male therapists that are working. So they're kind of few and far between. But I think that's great for some people who may feel more comfortable, or for some people, who may feel more comfortable with a male therapist, whatever makes you comfortable. So it's definitely private, one-on-one, a lot of talking. You should feel comfortable. It should not be painful. And it is in a private room. That's the biggest thing that I think people don't, they're thinking, oh my goodness, it's just in one of those curtain stalls. I'm like, no way.
Awesome. Well, thank you for that. It really kind of helps, I think, probably dispel some of the myths and the worries, hopefully for some. And then Uma, will you tell us like what treatment might look like? So Alana kind of told us about what to expect for the assessment, but let's say you find some dysfunction of some sort. What might treatment kind of include?
Yeah, so our treatments are really highly based on what we find with that assessment. So Alana went through all the different things that we go through, and we have the luxury of time. We have so much time to sit and listen to all of the details and talk about all the different systems. We're not kind of talking about different silos and different things. We have a lot of time to connect up all of those dots and really listen to a lot of those symptoms. And so the treatments are very much obviously dependent on what we uncover in that assessment. And the therapist and the client work together to figure out what the goals of treatment are. So of course, what we do for a urinary incontinence issue is going to be completely different than what we do for someone who presents with a pelvic pain issue. Now, some of the treatments that we do, straight up physiotherapy kind of stuff, right? Stretching, strengthening, exercise, all that kind of stuff. But sometimes we have to actually hone in on the actual pelvic floor and look at some of those muscles in specificity to look and see if there's scar tissue, if there's a pain issue, if we have to stretch, we have to loosen up some of the connective tissue around the area. We do external treatments as well as internal treatments. And then of course we have to provide a home exercise program or something for you to do at home, because I typically see my clients once a week. And so there's 6 days of the week that you need to go home and do something. So there's some carryover, and that we make progressions in your symptoms and improvements in hopefully in your symptoms. And we do a lot of counseling. There are a lot of things that we talk about that you would never even consider to even have any influence over your pelvic floor. For example, we talk about sleep hygiene and stress management and water intake and how to sit on a toilet so that you can actually even have a bowel movement. We talk about coping mechanisms and mindfulness and dietary fiber and on and on and on. There's so many different things. There's a huge, huge component of education that does go along with what we do, because if you're sleeping 3 hours a night and we're here talking about pain, well, we're going to be seeing each other for a really long time if we never address that sleep issue, right? So there is a lot of counsel and education that goes along with what we do. Now, I know a lot of you are sitting at home thinking, is she going to talk about Kegels? Well, that was by design. I kept that for the end because I want to talk about that as a totally separate issue. So Kegel exercises, and let's call them pelvic floor contractions now, right? So pelvic floor contractions are basically zooming in on a group of muscles and attacking them like they work in complete isolation with no influence from any other system. So hopefully one of the things that we've really driven home today is that these muscles do not work in complete isolation. They are part of a huge system. They are influenced by a lot of things. And so we really never want to hone in and do exercises specifically just for this one group of muscles. It's a great jumping off point. We can see if you even know how to find these muscles. Do they work really well? Do you have a local weakness issue? But from there, we have to really zoom out and try to look at, or try to mimic at least closely to what the conditions are that you actually have symptoms. Not in my career have I ever had a single person that came in and said, I leak only when I'm lying down on my back on the bed. That's never ever happened, right? So that's the first thing about Kegels. The second thing about Kegels is that we have to determine what the state of your muscles are. We've already alluded to the fact that your muscles can be shortened and tight, and they can also be weakened. So if you take a short and tightened muscle and load it up and make it start working even more, you run the risk of, first of all, not doing anything, making no progress at all, or you run the risk of also making your situation worse. So Kegels are not for everybody, and Alana already said that. So that's a major take-home message we want for people. Kegels are not a one-size-fits-all. The last thing I want to say about Kegels is that if you're going to show somebody how to do Kegels, there is very strong evidence that supports the fact that you cannot verbally or with words on a paper instruct somebody as to how to perform these contractions. If you're stuck with verbal instructions and your imagination to work with a group of muscles that you can't even see with your eyes, well, good luck. That's not really going to work out very well, right? So those are 3 reasons why it's really not just about Kegel exercises. And the last thing I want to say, if it sounds too good to be true to be sitting on a magical chair that's going to Kegel your pelvic floor 1,000 times in 5 minutes while you sit back and read a magazine, well, everyone here is an informed consumer now, so I'm going to leave that up to you to decide whether or not that actually is too good to be true. So take home message, Kegels are not it.
Thank you, Uma. That was really great. And thank you for kind of giving everyone an overview of the different things that treatment can include, but also things to be mindful of when you're looking for treatment. All right, last question before we open it up to some questions from the chat. So if anyone, or Q&A, if anyone has any questions that they want that they haven't had answered yet, please go ahead and keep firing those in. I know the pelvic floor physios that are in the chat have been very active. Lynn, I'm going to go with you for one more question just about treatment. What are the success rates of pelvic floor physiotherapy treatment for addressing pelvic floor dysfunction that we've been talking about tonight?
I love that question because, again, as I think we've said, it's not just a matter of, we're not going to teach you how to just strengthen your pelvic floor. And that's why it's so important to have we'll teach you how to strengthen your pelvic floor, but for, I would say, a good like 70% of the people that end up walking into my office, the problem is that they're actually already in this too tight protective response. So if your muscle, this is a weird thing for people to understand, but if your muscle is too tight, it's weak. Inherently, a tight muscle is a weak muscle. It's going to lose communication with your bladder. Again, it can't be that trampoline that can take on impact. I always tell people it's almost like you're holding 2 grocery bags. My muscles are busy. They're tight. All of the muscle fibers are overlapped. They can't take anymore. If you throw a watermelon at me, it's going to end up on the floor because I can't do anything more. So it's really when you can actually have an evaluation to figure out what is wrong with you, not the 3 people I saw before you. Where are you weak? Where are you tight? What are all the other factors that go along to make you a whole person? Then it has a huge rate of success. We know welcome to the wonderful world of women's health, where we are actively trying to pursue a lot of different research and strategies. There has not been a ton of research in women's health. I think it wasn't until 1993 where they even opened up women who are in childbearing years being able to be subjects in research. So that wasn't that long ago. So a lot of the research we have on things really has to do with male subjects. So that's why this is waking up. And now we're realizing we really have to look at, 51% of the population that are have this female anatomy, and we have different fluxes in hormones. So when we look at just incontinence alone, that they've done research on, we found that 100% that should be the absolute first line treatment that people do for an inability to control urine. So whether it's stress urinary incontinence or urge incontinence, or you can have a mix. Some people, when it progresses too long, have a bit of stress urinary incontinence, the coughing, laughing, sneezing, running, and that, oh my goodness, I have to go now and I'm not going to make it to the bathroom. And then they start peeing just in case all the time. So that has a very high, like they look at when they're doing research, what should be like the first line treatments. And they've across the board, every urologist, gynecologist, urogynecologist should be telling you it should be pelvic floor physio, so we can figure out what is going on. In terms of pain, we know for a lot of these people, whether it's endometriosis, whether you've had a hysterectomy, you've had any kind of surgery done to your abdomen, pelvis, a lot of people will have persistent pain. Let's say their endometriosis is under control. it's managed well from a medical standpoint, or same thing, your surgery's over. It went really well. The surgeon's thinking everything's great, but maybe you have all this persisting muscle tension or scar tissue or things that are, your nerves are getting bound up in some of this muscle tension. So we know that also, it's sometimes the only kind of solution for some of these people. So that has a very high rate of success as well. In terms of pelvic organ prolapse, I always tell people, generally with prolapse, what we care about is how dysfunctional it is to you. So if people have pelvic organ prolapse, I've seen people who walk in and I'm looking at them on their physical exam thinking, I don't know how they're making it through their day, and it doesn't bother them at all. So that's what we care about, is what is it bother? What's the bother to you? What's the lifestyle changes you're experiencing? So we know with pelvic organ prolapse, if it's mild to moderate pelvic organ prolapse, often we can help. And again, we're looking at all the other things: constipation, how is your pressure management? Do you have weakness? Do you have tightness? There's all these things. So we definitely can make a change with that. Once you get to a severe pelvic organ prolapse, you grade them. So once you're getting to severe, that's grade 4, where actually like this organ is now coming outside of your body. Often those times we're going to look for something external. So a lot of pelvic floor physios can fit you with what's called a pessary. A pessary is like an internal splint. Or that's probably surgical. And I'm honest with people. I'll tell people pelvic floor physio isn't going to hurt you by any means, and it may help you get over surgery in the end, but it's definitely not going to fix the problem if that's what people are looking for in the most severe cases of prolapse. So yeah, generally we would work together to determine your goals and figure out, honestly, what would be successful and what wouldn't be. So generally high rates of success, I would say.
Thank you, Alana. So that's great. All right. So there are some great themes and questions in the chat. I've been kind of watching and trying to jot them down as we go along. I am going to put up a slide just while we kind of go through a few of these, because one of the big questions people are saying is like, how do I get help, or where do I go to get help? So of course we want to make sure that we give that to you. So I'm just going to put up a slide that has some key information about how you can find a pelvic physiotherapist with Lifemark in a variety of different ways. And we definitely encourage you to connect with us on social as well, because things like this get promoted in other blogs and other information things as well. So I'm going to go first about lots of questions about leaking kind of for years. I saw a bunch of people in the chat about like, what happens when you have jumping jacks. I always kind of pee myself a little bit when this happens. Doing Kegels, Uma, you told us maybe not be the be all end all. The theme is, I've been leaking for years, religiously doing Kegels, doesn't seem to be helping. What might my next steps be? I don't know if you want to take that, Uma, or.
Yeah, so again, as I alluded to before, that doing Kegel exercises is, if I can give you an example, if you told me that you were running 10K and 5 minutes into your run, your knee starts to hurt, and I say, great, I want you to go home and put your knee up on a stool and tighten your thigh muscle 100 times, and that should fix your problem. Well, you would look at me like, first of all, you're a crazy lady, and what crackpot school did you go to, right? But that's essentially the same thing as telling somebody who's leaking to go home and do these contractions, and that's going to be the be all end all. So a lot of other factors do influence incontinence, like hip strength, for instance, or core breathing mechanics, posture, a lot of different things. So if you have been trying Kegel exercises and not getting anywhere with them, then there's probably something a little bit more involved going on with your symptoms, which might require someone to assess. And again, if you have a tight pelvic floor, for instance, doing Kegel exercises is not going to help with a tight trampoline. So you might need to have things kind of stretched out. You might need to be cued in terms of alignment and posture. Can we optimize that pressure system? And then also coordinate that with whatever the actual activity is that you have leaking with. So someone who leaks when they're bending down to pick up a child, for instance, is going to have to do different things than someone who leaks 5K into a 10K run. That's a completely different situation. You have to sort of treat that a little bit differently. So it might just be something that requires a little bit more involved and a trained eye to really kind of zoom out and kind of take a look at that whole picture and sort of give you more specific training for your specific issue.
And we've also known that now a lot of women who when in research, we've looked at how many women, from me just saying, do a Kegel. I mean, a Kegel is, you know, a lovely gynecologist in the 1940s, Arnold Kegel, figured out that for a subset of women, if they can strengthen these pelvic floor muscles, they get better. But that doesn't really tell you what to do. And we know that it was in excess of 60% of women can't engage their pelvic floor musculature properly with just verbal cueing alone. So we don't really even know if you're doing it right, because I shouldn't be able to see anything from the outside. I always joke, these are your private parts, so the exercises should also be private. Shouldn't be able to see any of them.
Yeah, well, actually, one thing I should also mention is that there's actually statistically 80% of people with low back pain also have stress incontinence. So if there's a back issue also underlying going on in addition to the stress incontinence issue, like those are two things that have to be also addressed because they do play off of one another. So it might not just be a stress incontinence issue that you're dealing with, there might be other things going on there too.
Great. Thank you. And I just want to alert you, like, we're already like at an hour, but we'll do a few more questions because there's some great questions in the chat. If anyone does feel like that they need to drop off, because I know it's getting late in Atlantic Canada, we are recording and you'll be able to watch the rest afterwards. Question about pain with intercourse. A couple of people have been saying that, you know, they've had pain with intercourse after giving birth and having given birth quite a number of years ago. And it's been getting worse. So, you know, 20 years has passed since their birth giving, and the pain is getting worse. Is this something that pelvic floor physiotherapy can actually help with?
Yeah, I think because so it's hard to say for sure. Like sometimes depending on what your history is with your delivery and, you know, how much trauma there was, sometimes it can be held on muscular tension because, again, your muscles are still in that protective state. A lot of times we see people who have a bit of like kind of stuck scar tissue that kind of has to be moved, or some nerves that are also have maybe been kind of impacted by kind of some tension or some traction from delivery. And also it just depends also how old you are. So sometimes, again, several years after you've had a baby, then all of a sudden your hormones start declining. And so that's when, again, we'll see the changes that are associated with some lower estrogen levels. So people do get drier, frailer skin, and it's easier to have tearing and irritation, and it becomes really painful. And it's very easy to fix. And we can kind of guide people in that way as well. And it also depends on even earlier on postpartum. It's kind of a bad design that, especially if you're breastfeeding, the hormones that allow you to be able to breastfeed, your prolactin and oxytocin, actually suppress estrogen. So when you're nourishing your child, you're actually in this, you know, estrogen suppressed state, which does have an impact on some of your tissue in your vaginal area. So
yes.
Help.
And also don't forget also that pain is a response to threat, right? So it is something that your brain sends out a signal for when it perceives something that you need to protect yourself against. And so all it takes is one unpleasant experience and that goes in the vault. And then all of a sudden, even just thinking about intercourse is enough to get you to tighten up and feel anxious and all the rest. So that's also part of it too, is that you kind of, this is a nervous system issue too. Like it's not just local issues, but there's a nervous system component that kind of goes along with that too. So you have to address kind of on both ends.
Great, thank you. I have seen in the chat a number of male participants who have joined us tonight, which is great because men have pelvic floors too. And a couple of things I've seen is that saying they've had difficulty with urination for a few years and been to a urologist maybe or physicians and been told that there's kind of no options for them. Is there options for that sort of a problem for the male population as it relates to pelvic floor physiotherapy?
Mm-hmm. Yeah, so males who start to experience urinary dysfunction, and we're talking more about the slow flow, stop and go flow, urinary retention kind of sort of symptoms. Unfortunately, the prostate is really what gets blamed for a lot of these issues. And so a lot of men will go down this whole rabbit hole of going to see their GPs and getting referred to urologists, and they are under the assumption that there's a prostate issue, will be put on antibiotics, and we'll just go on a journey for years of, using antibiotics. Things get better, then the symptoms come back, we'll put on more antibiotics, and then all of a sudden, you spent a whole year being on antibiotics. Whereas there's never even been any confirmation that it's actually a bacterial infection of any kind whatsoever. So when so men have symptoms of pelvic floor dysfunction that will impact issues like urination, that, obviously if you're having slow flow, stop and go flow, your muscles are tight because the muscles have to be able to release for you to actually evacuate. And then once you're put on courses and courses of antibiotics, if there's really no confirmation that there's any bad bacteria, you're wiping out all the good stuff. And so that's going to affect your gut. It will probably lead into constipation issues, which will further irritate all of the muscles in the pelvic floor, in addition to your bladder. And also there will be likely some sexual functioning issues that will also come up with that too. So pain with erections, pain with ejaculation, pain with bowel movements. And so this actually, unfortunately, is an exceptionally common symptom that occurs with men, and it's not unique to age either. I have treated men as young as 19 all the way up into 80s and 90s. And so this is a very, very common thing that does happen to men. Again, under the guise of a prostate inflammation type of issue, but in reality, it's actually pelvic floor dysfunction. So if this sounds familiar to anyone that's out there, yes, you should probably go see a pelvic floor physio.
Yep. To you or to your spouse or to your friend or any of those people as well. Awesome. Well, I know that there's always a ton of questions, and I feel like we could be here for hours and hours and hours trying to answer them all. I will let everyone who's still with us tonight to let you know that we will still look at all of the questions that came into the Q&A. We actually use that information to try and help inform, blogs that we write and publish on our website or share on our social channels. So we definitely encourage you to follow us. As shown on your slide, on the slide right now. As I said at the beginning, you will receive an email within about 24 to 48 hours after tonight with a link directly to the recording. So if you missed anything or want to go back to it, you can do that. But also you can share it with your friends and your family as well. And we will also post that on our website in short order. But we will be asking for your feedback. So please feel free to give us your thoughts about what you liked about tonight, what other topics you might want to see. And then we will use your Q&A to help inform what next steps we can take and share other information with you. I'm going to just take the share down here for just a second. I just want to say thank you, Uma and Alana, for this evening. I always love to listen to the two of you talk about the pelvic floor so openly and honestly. So I really appreciate you sharing your knowledge with all of us and all of our participants. And thank you to everyone who joined us this evening. We really appreciate you giving us your time and just having interest also in pelvic health and women's health particularly. And then obviously lastly, but not least, thank you to our partners at PC Health and the great initiative that they are doing about trying to donate or donating funds towards supporting women's health equity, which we really obviously have already also talked about in tonight's session. So thank you, everyone. Have a lovely evening. Happy International Women's Day tomorrow. And we thank you all again and have a lovely evening.